session today on fertility preservation, the autoimmune polyglandular syndrome type 1. It's my pleasure to introduce Dr. Senapati, and Dr. Witzke. Dr. Senapati comes from is the assistant professor at the University of Penn Perelman School of Medicine and practices reproductive endocrinology and infertility at Penn Fertility Care. If you would like to come up and take a seat. And then we have Dr. Witzke. Dr. Witzke serves as the operations administrator at the Ronald Perelman and Claudia Cohen Center for Reproductive Medicine of Weill Cornell Medical College. So welcome, Dr. Witzke.
Can you guys hear us okay?
Yes.
Wonderful. Okay, so first of all, I just want to thank the organizers of this meeting for the opportunity to come speak to you guys about fertility preservation, which is something that is very near and dear to my heart. As our moderators have mentioned, I am at the University of Pennsylvania. So I work both at the hospital at the University of Pennsylvania with our adult women who are pursuing fertility preservation, as well as at the Children's Hospital of Philadelphia with our pediatric endocrinology and fertility preservation teams there as well. So basically, over the course of this next hour or so, we're going to walk you through some of the basics of female and male infertility, just to get a baseline understanding of where we are coming from, as well as how issues with fertility can potentially impact autoimmune disorders and APS type 1 in particular. Then we'll be going through some of the different fertility preservation options that are available in general and those that we feel might be more pertinent to patients with APS type 1. And then certainly talk through some of the factors that impact decision making. This is very critical because each patient in each scenario is going to be very different based on when a patient is presenting to us for the first time, what exactly is going on in terms of the management of the various aspects of their APS, as well as also, other social and resource issues that come into play. And then finally, we'll be walking through some clinical case scenarios that are fairly general, but allow us to kind of show you a little bit about how we approach things from the perspective of surveillance and sort of monitoring of fertility, as well as making management decisions as they become applicable. So this next hour is really for you. So, we put together slides to go through content, but we also want this to be relatively informal as well. So if you have questions as we are going along, please do not hesitate to ask them. We will certainly have time at the end for questions and answers, but we want to make sure that you're getting what you want out of this hour with us today. So the people in this room know more about type 1 APS than the vast majority of people out there, so I don't need to say too much other than to remind us that we are talking about a disease that is largely due to genetic variations and an autosomal recessive disorder caused by pathogenic variants in the gene AIRE. So this becomes particularly important when we're talking about fertility because this is theoretically a disease that could be passed on in future generations in some cases. And some of the fertility preservation options that we're going to talk about will not change that risk. And some of them actually can potentially offer the option of risk reduction. It's also important to note that the age of onset for this disease is usually sometime in childhood or in adolescence, more rarely presenting as sort of an adult onset disease. And this becomes important when we talk about fertility because the different fertility preservation options may differ based on whether a child has gone through puberty yet or not, as well as certainly the severity of disease. And so some of the clinical features that we're all familiar with include recurrent fungal infections of the skin and mucous membranes, parathyroid and adrenal gland dysfunction, fatigue, muscle weakness, cramping, tingling, loss of appetite, and weight loss. And so really, none of these things individually are contraindications to fertility preservation technologies. But as with any clinical scenario, we need to take into consideration what are the different parts that are being most affected in the particular patient that we're seeing, and what do we need to do to safely get someone through the fertility preservation process. So as we discussed previously, the disease severity is very unpredictable, and that's a big factor in terms of making decisions about fertility preservation. But the good news is, with current treatments, many people will have a normal lifespan. So in addition to kind of maintenance of the disease, now quality of life issues come into play. And a major one for a lot of individuals and families is the ability to have a family in the future. And so that's where fertility preservation can be helpful because in this disease, there is a very variable impact on fertility, both in men and in women. And we'll talk a little bit more about sort of the prevalence of ovarian insufficiency in this disease process, as well as kind of the differences that we see amongst males and females. Now, I mentioned that we're going to need to talk a little bit about fertility because this is somewhat of a new concept in fertility preservation as it relates to this particular disorder. So when we talk about fertility, fertility can be impacted in a variety of different ways in a female or male individual. So it can be impacted by how the ovaries are functioning. It can be impacted by how the anatomy is functioning. So features like, are the fallopian tubes normal and open, as well as uterine function. Of these three components, ovarian function is the one that is most pertinent to APS type 1 because what we can see is that some women, not all, but some, will go through premature ovarian insufficiency, or basically will go through menopause at an earlier age. It can be very difficult to predict exactly who that will happen to and when that will occur. And so this is where sort of the multidisciplinary approach of working with one's endocrinologist, general practitioner, as well as potentially a consultation with a reproductive endocrinologist can be helpful. Now, on the male side of things, we do also see some changes in some men in terms of their sperm parameters, so sperm counts, for example. There are other elements that go into male fertility as well, including anatomic variations like obstructive processes and certainly physiologic function. So some men with chronic medical conditions can have some problems with erectile dysfunction or ejaculation, but primarily what we see in terms of the male fertility side of things is an impact on sperm counts and occasionally sperm motility. So I'm going to turn it over to Justine now, and she's going to talk to you a little bit more about female fertility.
Thank you very much for having me. So with any woman, we know that fertility declines with age. And this is something that starts, and we'll talk about it a little bit more in a later slide, starts even before we're actually born. But more notable decreases in ovarian function do start around the age of 32. And then the rate of decline of ovarian reserve increases at about age 37. So as you can see in this graph, as women are getting older, the rate of decline of their ovarian function is increasing. And what is also happening at the same time is that these eggs that are available, which are fewer than there were before, have higher rates of chromosomal aneuploidy or chromosomal disorders. So you can see here that this image actually shows the first half of it is prior to being born. That young girls, babies, have their highest number of ovarian follicles at about 20 weeks gestation. And that number of ovarian follicles is constantly declining from that point. There are certain treatments that do impact this as well. So if someone undergoes chemotherapy or radiation, we look at that as something that will sort of age the ovary at a more rapid rate. With certain chemotherapies, this is about a 10-year difference, that if someone is actually 30, their ovaries look about like someone who's naturally 40. And as was said earlier, the impact from autoimmune disorders is variable depending on the condition itself. So there are, as you are all the experts on this, there are a number of different autoimmune disorders that can impact fertility differently. About 20% of patients who have premature ovarian insufficiency have that because of some autoimmune disorder. And the conditions are listed here of the different impacts, and APS type 1 is one that the ovarian impact is significant. Okay, and segue into that. So the studies that are out there, which albeit are limited, are showing that the POI or POF, as it was formerly called, develops in sometimes 3/4 of patients. And the age of onset of the POF is quite variable. So the average age was 24 years, but the range, some patients had POF at about 14 years old, which definitely can change the management of how fertility preservation would be recommended. And for males, the information is more promising in terms of fertility. Only about 2% of males are believed to have real infertility, but there's certainly some understanding that there's subfertility in more males than that. So for males, the fertility preservation options, there are two. If the male has passed puberty and is able to provide semen samples, those samples can be frozen. This is the standard of care, has been done for many, many years, and many, many babies have been born from sperm that is previously frozen. Under a research protocol, there is the option in some institutions for young boys to have testicular tissue frozen. At this point, there are no babies ever born from previously frozen testicular tissue. So this is something that definitely is in the developmental stage, but may be promising as we're moving forward in science. For females, there are a number of options for fertility preservation. The two kind of most common options that people hear about are oocyte cryopreservation or egg cryopreservation. So this is the freezing of unfertilized eggs so that that person could potentially use them in the future. Another alternative would be embryo freezing. And this can be done with a patient's egg and her partner's sperm, or it could be done with donor sperm, depending on the situation and the family building plan. For young girls or people who don't have time to go through the ovarian stimulation, which we will get into in a little bit, we can do ovarian tissue cryopreservation, which is a procedure where a whole ovary or a portion of an ovary is removed during a laparoscopic procedure, frozen, and then potentially able to be used in the future for fertility. And then there are some other options. There is the use of GnRH agonists, which we will talk about a little bit more later, that can potentially suppress ovarian function as one potential method of fertility preservation. And then there's certainly other family building options. So there's third-party reproduction that can include donor eggs, donor sperm, the use of a gestational carrier, or adoption. And we will get into more information on that in a moment. Turn it back over.
Okay, so as we mentioned, the two fertility preservation technologies for females that are probably most applicable to the APS type 1 patient population are going to be egg or embryo cryopreservation and ovarian tissue cryopreservation. So we're going to spend a little bit of time talking through what all those entail. So both egg and embryo cryopreservation begin with the process of ovarian stimulation. So basically what this entails is a 2-week or roughly 2-week time frame in which a woman is taking, a woman or a young girl is taking daily injections of gonadotropins or FSH. And the goal of these medications is to get multiple eggs to grow at the same time. So in a natural cycle, and unmedicated, kind of normally cycling individual. Each month, the body recruits a group of eggs from that very, very large pool of hundreds of thousands of eggs. And in a natural cycle, one of those eggs becomes larger, has the capability of, has the maturity or has the capability of being fertilized for a pregnancy, theoretically. And the rest of those in that group die off. So that's kind of the natural process of ovarian aging that occurs, that recruitment and atresia. So what ovarian stimulation is designed to do is that group of eggs that the body has recruited in that particular month, the medicines are trying to rescue those other eggs from undergoing atresia, and so or dying in the natural way. So the injectable FSH medications are trying to get multiple eggs to grow on the ovaries. Now, during this 2-week process, girls or women will be undergoing very frequent ultrasound monitoring. And so this is pelvic ultrasounds to evaluate the ovaries and to actually measure these fluid-filled sacs called follicles. Those are basically the homes for eggs, as what I often will tell patients, because we can't see the eggs. The eggs are microscopic, so we have to use other substitutes to watch the eggs grow and develop. During this time frame, there's also blood monitoring of different hormone levels, with estrogen being the most important, and that helps us as clinicians to make sure that patients are getting the right dose of medication and to also make decisions about how long someone should be going through this ovarian stimulation process. After about a 2-week period, once we determine that we are expecting to get a group of mature eggs, then that patient will undergo an egg retrieval or an oocyte retrieval. So this is a minor surgical procedure that is done under anesthesia in most settings here in the U.S. It can theoretically be done under local anesthesia and often is outside the U.S. But it's a same-day surgical procedure, does not necessarily require a hospital stay. And basically, we go in and retrieve those eggs, and then there's basically 2 pathways. One is that those eggs can be frozen or cryopreserved right then and there for future use. Or in the setting of a woman who may have a partner at the time, or who might, for other reasons, want to conceive with donor sperm. The egg and the sperm can be put together in the laboratory, and the resulting embryos are typically cultured for anywhere from 2 to 5 days. In our laboratory, we usually will culture them for 5 days, and then cryopreserve or freeze them through a process called vitrification. So the main risks of this process to the patient are from having relatively high estrogen levels for that time frame, as well as the surgical procedure itself. So those high estrogen levels in some individuals can make them a little bit more prone to blood clots. And also, there are some women who will actually over-respond to the medications that we give. That doesn't happen very often. That happens in about 1 to 3% of all of the patients that we kind of take through the stimulation process. So really, the risks are the high estrogen levels, potential thrombosis or clotting risk, and then a small risk of bleeding associated with the actual surgical extraction procedure. But overall, that risk is pretty low, less than 1%. Now, the most important kind of component of this is that we really need to be working with a patient who has begun the process of puberty. So that doesn't necessarily mean that they would have had to have had their first menstrual cycle, but generally speaking, this is done in women who have already initiated their menstrual cycles, or girls who have already initiated their menstrual cycles, or kind of the earliest that it's been reported is in a girl who has started to go through some of the other changes of puberty, but may not necessarily have hit menarche yet. So we'll show you kind of what that looks like as well. So these pictures are basically showing you various aspects of the oocyte or embryo cryopreservation process. So what these 2 pictures are showing here are what we are looking for when we are doing the ultrasound monitoring. So there we go. So this is a picture of a transvaginal ultrasound. So most of the monitoring that is done for this process is done with vaginal ultrasounds. In some cases, we can do abdominal ultrasounds monitoring, and very rarely we will actually do abdominal egg retrievals as well, but for the most part, most of this is done with vaginal monitoring. And so what we're looking at here is this structure is an ovary, and this black area right here is a follicle. So this is someone who basically came in at the start of ovarian stimulation. They haven't seen any of the fertility medications yet. So what we'll see is an ovary, and we'll see many small black circles. Then after several days of medications, we see these black circles, which are antral follicles, grow in response to the gonadotropins. So these frequent monitoring visits, the purpose of them is to measure these follicles and to watch them grow and develop over time. And so every time someone comes in, they're getting measurements of each of these follicles because we're shooting to get a good group of them in about the 18 to 20 millimeter range before we go in and do the egg retrieval. So this is a graphic that's taken from a New England Journal of Medicine article by Dr. Van Voorhees out in Iowa from 2007. So you guys are looking for a reference in terms of a little bit more about this IVF process. This is a great one. But this picture is was developed basically to show how exactly the probe goes in and how the needle is able to access the ovary. So basically the same method that we use for monitoring, we place a sterile needle at the tip of the ultrasound probe, go in through the vagina into the ovary, and we remove the fluid from each of those follicles that have been developing in response to the medication. So with this technique, there's no incisions on the abdomen and really no incisions anywhere. There can be a little bit of light bleeding after the procedure, just from where we go in with the needle, but that tends to be pretty minimal. And then afterwards, the fluid that's retrieved from each of the follicles on the ovary goes to our embryology lab. And so we have embryologists who, in real time, right then and there, look at the fluid and can identify the eggs. And then the eggs are basically prepared for the freezing process, and that day they are frozen. So from a patient perspective, it can be an intensive couple of weeks of stimulation, but at the day of the egg retrieval, you know kind of what the outcome is. It's not something that you have to wait several days to find out how many eggs were retrieved or frozen or anything of that nature. So this video, let's see if we can get this to run. So this is a video of a patient who undergoing the egg retrieval process. So basically what we're seeing here is this is the ovary, and this white line up here is the needle that's being introduced. And what you'll see is this needle is being basically placed in each of these black circles, and with a suction device, that fluid is being basically slowly drawn out of each of those follicles. This is done under ultrasound guidance to minimize any risks to surrounding structures like bowel and bladder. And it's usually a relatively rapid procedure, somewhere in the range of 20 to 30 minutes. Again, these are done under anesthesia and typically can be done and are done by most fertility programs in an outpatient surgery center. Occasionally, if there are medical reasons why we need to do this in a hospital-based setting, there are a few places around the country that can accommodate that. And as I mentioned, this is a procedure that's done under anesthesia, which is essentially conscious sedation. So one does not need to be intubated for this procedure, but the patients are put to sleep and they don't feel any pain theoretically during the procedure. Okay, so many of you are probably asking or thinking, wow, this seems really invasive for a young girl. The reality of the situation is that a lot of girls are able to tolerate both the vaginal monitoring as well as the procedure because it is done under anesthesia. As I mentioned, there are some settings in which we will do abdominal monitoring in young girls, and we do have some experience nationally with ovarian stimulation in adolescents, although the data at this point is relatively limited. So this slide was put together to show you a couple of different case scenarios of young girls who have gone through this ovarian stimulation process. So the two cases that are in these first two columns on your left are from, this one is actually from, I want to say this one is from Cornell. Yes, this one is from Cornell, and this is from another group in New York, Dr. Aktay's group. And then these two were for patients that underwent ovarian stimulation for other medical conditions, but were in adolescence. So this first case is a case report of a 13-year-old who presented with myelodysplastic syndrome, which is a type of blood disorder. And she had actually not gone through menarche yet. She hadn't started her periods yet. But she had already had some breast development, kind of the early stages, Tanner 3. And when she had ovarian reserve testing done, which we'll talk about shortly, it showed that her FSH was within normal limits, and her AMH was about 0.95. So she underwent ovarian stimulation and tolerated it without complications, and ultimately had 20 eggs that were retrieved, and 18 of which were mature or, basically reserved for cryopreservation. The second case here is one of a patient who had had a germ cell tumor or a particular type of ovarian cancer and had to have her one of her ovaries removed. She was 15 years old, had already started having menstrual cycles, and her ovarian reserve parameters were generally within normal limits as well. So the remaining ovary had 11 antral follicles on it. At the time of assessment, she had a normal FSH and her AMH was 1.6. So she went through ovarian stimulation for 11 days, and ultimately we were able to cryopreserve 8 eggs. And then similarly, there are two other cases here, one of another patient who had an ovarian cancer, and another with a sarcoma, which was a type of musculoskeletal disorder. And what you can see here is the egg yield is variable, but we are certainly able to stimulate girls that are in this age range. I think the biggest unknown, though, is because so many of these young girls are having this procedure done, we don't actually have a lot of data yet to tell us what the pregnancy rates are going to be from these ovarian stimulation cycles. So this is a big area of research at Penn, Cornell, and various other academic institutions around the country that have a focus or emphasis in fertility preservation to really have an understanding of what is the utilization of these eggs at a later time. I can certainly speak to our experience in adult women in terms of, we have had many cases of patients coming back having cryopreserved eggs and are able to have successful pregnancies later. But some of these patients also who undergo cryopreservation may choose not to use the eggs because either they were able to conceive on their own or they underwent other fertility treatments later in life that were not necessarily based on in vitro fertilization, but some of the less aggressive fertility treatments and conceived that way. So there's a very wide spectrum in terms of what one can do and ultimately whether or not one ultimately uses those eggs in the future. So the next topic we want to talk a little bit more about is ovarian tissue cryopreservation. So this method does not require ovarian stimulation, does not require the 2 weeks of injectable medications. And so this is an option that is also theoretically available to prepubertal girls, so girls who have not gone through any of the puberty or menarchal changes. It does require a laparoscopy, which is a surgical procedure that is done under general anesthesia involving small incisions on the abdomen where a camera is placed inside, and then through very small incisions, usually about 1 centimeter, a piece of ovarian tissue is removed. Now, in many patients, if they're having another procedure done, particularly in our patients who, for example, in our cancer patients who might be getting a port placed or something of that nature, we'll try to combine these procedures, both so that, one, the patient doesn't have to undergo anesthesia multiple times, and two, this can also facilitate, from a resource perspective, insurance coverage and other issues that can come up with fertility preservation. Currently using ovarian tissue cryopreservation does require reimplantation of the tissue at another time. So the idea is that the tissue is cryopreserved, and if that patient ultimately becomes menopausal or has ovarian failure, then at a later time she would have a surgical procedure to have that tissue thawed and put back inside of her. Usually it will be placed on the ovary, but sometimes it can be placed in other areas inside the abdomen. And then that tissue will then be, so then the patient will be given medications to stimulate the eggs on that tissue. Theoretically, there may be the option in the future to take eggs from that ovarian tissue that's cryopreserved and actually mature eggs in the laboratory in a method that would allow for eggs and sperm to be put together and then a pregnancy to be transferred back inside of the patient, kind of utilizing IVF technologies. As of right now, this is not something that is being routinely done in humans. There's still some quirks that we are working on in the laboratory, but this could be something that, over the course of the next 5 to 10 years could really see some improvement. Ovarian tissue cryopreservation is not as prevalent in terms of availability as ovarian stimulation. So ovarian stimulation for egg and embryo cryopreservation, there are many academic centers around the country and also a lot of private fertility clinics that may be able to offer this. Ovarian tissue cryopreservation is still considered experimental, so it is primarily done under research protocols at academic institutions that have an interest in fertility preservation. So Penn, for example, does it. I believe Cornell does, UCSF out in California, and there are, I think McGee in Pittsburgh, there are a few select centers that offer this. So these pictures basically show what exactly this procedure entails. So this top picture on the left is a picture from a laparoscopy, and this white structure right here is the ovary. And what you're seeing here are scissors are being used to separate the ovarian cortex. So the ovarian cortex is sort of the outer surface of the ovary, and that's where the eggs lie. So in this particular case, we are peeling off a piece of that cortical tissue, and basically we end up with these little strips that are just a couple centimeters long, and then they are cut up and cryopreserved in that fashion. Now, as I mentioned, theoretically, one could then at a later time transplant this tissue back. So we have done a couple of these at Penn, not a great number, but basically this is an adult woman in whom this was done. So this was a patient who was actually a cancer patient who had lymphoma, and she was going to be getting chemotherapy that was toxic to her ovaries. So she underwent the ovarian tissue cryopreservation process, went through chemotherapy, was disease-free, and about 4 years after, she came back and said, okay, I'm not cycling, so I'm, clearly in menopause or have premature ovarian insufficiency, and I'd like to try to use this tissue again. So she had another laparoscopy to go in and take the tissue that had been cryopreserved. We thawed it and basically sutured it to where her ovary was previously. So basically trying to take advantage of the fact that that organ still has good blood supply and to keep that tissue functional. So looking internationally, there have actually been live births from ovarian tissue cryopreservation. There's a little over 60. I think that number is actually up to 80 now. There, as I mentioned, there are a few select centers around the country that will offer this. Okay, I'm going to turn it back to Justine to talk about some of the rest.
Okay. So the next thing that we're going to talk about, I briefly mentioned earlier, is this GnRH agonist, which is the brand name of this drug is called Lupron. And this is something that somewhat controversial in the sense that there are some studies showing that it has been effective for some patients for fertility preservation purposes, and other studies showing that there's not really much difference if this is administered. So this is a medication that is administered by injection, and the purpose of it is to act on the ovary and ultimately suppress the ovarian function, with the idea being that then there's less atresia of those oocytes, and ultimately there could be greater ovarian function in the future. But it's not something that is standardly used by every reproductive endocrinologist for the purpose of fertility preservation, but it is something that you may come across as you're doing research in this area. And then, for building a family, there are obviously many, many ways that this can be done. And we see at all of our centers many patients who are coming to use the gametes of other people who have altruistically donated their eggs or sperm for the purpose of other family building. And this is something that can be done. It's an IVF process, so the egg donor goes through essentially the IVF process that was explained earlier, and then embryos are created and either transferred into the intended mother or potentially transferred into a gestational carrier. And a gestational carrier is someone who is not genetically related to the embryo, but is going to carry the pregnancy to term, hopefully, and often referred to as a surrogate. This can be autologous embryos, so embryos made from the couple who is trying to conceive, or could have donor gametes involved. And then certainly there are alternative options for family building as well, such as adoption. And we'll get into some of the resources at the end. And I know we don't have much time left, so I'm going to try to speed myself up here. But one of the things that's really, really important in doing this is to consider all of the factors in the decision making. There's certainly the risks of the procedures. There's certainly the success of these procedures and the fact that many of them are research protocols. The cost associated with it, they're not procedures that, many of them are not covered by insurance very well and can add up to be quite expensive. And then there's this other concept of what is the intention of actually using them? Is this something that the patient feels very strongly about or the family feels very strongly about, or is it something that is kind of more obscure and not really a likely plan? So it's very, very important to individualize the discussion, to talk to the experts, to talk to reproductive endocrinologists, and have people, kind of considering individual factors. And some of those factors that are taken into consideration are the actual health status of the person that might undergo these procedures, the age, pubertal stage, the actual ovarian function at the time, and whether it's something that is likely to be effective, and enough eggs can be frozen and used for later. The availability of the option, the cost, of course. It is a huge dedication of resources to do this. A lot of time, a lot of energy, a lot of money. And then for some people, there are social and ethical considerations related to the use of donor gametes or the disposition of embryos, depending on the situation. Okay, we're going back.
So we wanted to wrap up with a couple of case scenarios just to eliminate some of the decision making as well as some of the nuances of both evaluating fertility in these patients as well as making decisions about management. So this first case, for example, is a 16-year-old girl who has APS type 1. And this is a girl who did go through pubertal changes and is having regular menstrual cycles. However, her APS is at a point where she is requiring frequent hospitalizations. So theoretically, this is a case in which this girl could undergo ovarian tissue cryopreservation if she, in consultation with her doctors, felt that she was not well enough to undergo the ovarian stimulation process. Or if this is a situation where she's requiring frequent hospitalizations, but we have a window of time where things are relatively stable, then that might be a time frame that we could take this individual through oocyte cryopreservation. Now, at the beginning of this presentation, we talked a little bit about the prevalence of ovarian insufficiency as well as the range in age of onset. So anywhere from 40% up to, in some cases, 70, 72% of women may ultimately have premature ovarian insufficiency. It is not every individual. Unfortunately, there is no one test that can tell us, yes, this person will experience this, or no, she will not. It can also be extremely difficult to predict when such changes will occur. So that's where we kind of get into what are the tools that are available to help us surveil. Should this be a girl who says, maybe right now with how critical things are is not the right time to undergo fertility preservation treatment, but maybe when things are a little bit more stable in a few months, I would want to reconsider it, or potentially in a few years. So there's basically three mainstays of ovarian reserve testing. Two of them are blood tests, and one of them is an ultrasound test. The two blood tests are anti-Mullerian hormone and follicle-stimulating hormone. So anti-Mullerian hormone is a hormone that's produced by cells in the ovary, specifically the cells that support the eggs. And so we tend to worry when this level is very low. So the metrics that we use for establishing what is low has generally been developed in a population of women who are experiencing infertility. So the tricky part of that is we haven't fully figured out how to translate that to someone who has never ever tried to get pregnant, or to a young girl in whom she may not have necessarily reached the peak of what her AMH is going to be. So we'll come back to that concept in just a moment. The second blood test is follicle-stimulating hormone. So this is a hormone that the brain makes, or the pituitary gland makes. And so basically what we see is if the levels are very, very high at the beginning of someone's menstrual cycle, that can be a sign of either diminished ovarian reserve or, at a particular range, premature ovarian insufficiency. And then the third is pelvic ultrasound. And so that's when we can actually look at the ovaries and say, in this particular month, how many of that pool of thousands of eggs has the body recruited? So just to give you a sense of some of the challenges or limitations of ovarian reserve testing, AMH is the easiest because it doesn't require being done at a particular point in the cycle, but there's a lot of variation in what happens with AMH over time. And so from normative data, what we see is that an individual's peak AMH is probably around 24 to 25 years, which means assessing this level in an adolescent can be difficult because we might see levels that are low that may not actually be reflective of what the ultimate ovarian potential or reproductive potential may be. So while in adult women, AMH can be very helpful in terms of predicting response to treatment, in young girls and young women that may be more difficult. So in this population, we tend to actually rely more on antral follicle count and FSH. So if the antral follicle count is greater than 6, and if the FSH is less than 15, then those are predictors of better response than if the antral follicle count is low and the FSH is high. Okay, so any questions about that first case? Yes.
Are anti-ovarian antibodies or anti-21-hydroxylase antibodies at all predictive? Do they offer any benefit?
Really, not at all. I mean, as reproductive endocrinologists, we almost never will test for ovarian antibodies because they have not been predictive of either onset of premature ovarian insufficiency or time to. So the 21-hydroxylase has not been studied quite as well, so that certainly could be an area of future research. But as of right now, it is not used for monitoring. In the interest of time, I'm going to keep going. So the second case we have is a 24-year-old female, so someone who is past the point of adolescence, a young adult now, with regular menses with APS type 1, who has relatively well-controlled disease, is not requiring a lot of hospitalizations, is mostly being managed as an outpatient, and things are relatively well under control. So her main options here are probably going to be more along the lines of oocyte or egg cryopreservation, or potentially even embryo cryopreservation if she's with a committed partner. And so we did also want to touch briefly on the role of pre-implantation genetic testing. So the beginning of this talk, we opened this by saying that this is a disorder that does have a genetic link to it. There has been a particular gene that's been associated with this disease process. So with IVF and assisted reproductive technologies, there is the option of using these technologies to reduce the risk of having children that might be affected by this disorder. The way that process works is if a woman who has this disease goes through the process of ovarian stimulation, we retrieve her eggs, combine them with her partner's sperm, and assuming that her partner is negative for this disease, or even not in some cases, we can then biopsy the resulting embryos to determine which embryos may be affected, which may be carriers for this disease process, or which may be unaffected by the disease process. And then we use this information then to select which embryo would be optimal for putting back in the form of an embryo transfer to achieve a pregnancy. Now, we mentioned this as this may not be appropriate for each individual based on kind of whether or not whether or not egg or embryo cryopreservation is available to them, or whether this is something that is acceptable to them. So this is an area where there's a lot of ethical debate, but it is important that you guys are aware that the technology is available now. So if that is something of interest, it can be pursued usually with an infertility department's oversight. Okay, and jumping over to you. Yep. Mm-hmm.
Okay. So the next case that we wanted to kind of use as an example would be a 19-year-old female with irregular menses, which could potentially be an indicator of already seeing some diminished ovarian reserve and ovarian function, and her APS being well controlled. So she is someone who potentially, depending on the initial antral follicle count based on the blood work, could undergo ovarian stimulation and do oocyte cryopreservation, or potentially make, kind of have counseling with reproductive endocrinology specialists and the associated interdisciplinary teams, and decide that that's not something that she's interested in doing, and that she would rather consider third-party reproduction, whether it's through the use of donor eggs or through adoption later on. And then just briefly, even though this is not something that is seen all that frequently, we wanted to give just a couple of quick male examples. So if you had a male who has gone through puberty if he is, whether he's ill or if he's doing well, if he's able to provide sperm samples, then that's something that could be frozen and saved, and sometimes for many, many years can be used later. And then alternatively, if there was a young boy who is in a position based on his disease processes that he's in high likelihood for infertility or not doing well medically, there is as we mentioned earlier, the option for testicular tissue freezing, though this is something that is definitely experimental in nature at this time. And you can see here, and there are a number of resources that exist, kind of focusing on different facets of these processes. So there are a couple of resources, both Resolve, which is a patient advocacy group, and the American Society for Reproductive Medicine, that have many, many, many great resources about the processes involved in fertility treatment. Most of the fertility preservation specific information is going to be focused on cancer patients. That's where there's been a lot of effort put into this area. And two of the best ones are the Oncofertility Consortium, which is out of Northwestern, and the Alliance for Fertility Preservation. And both of those, I'll show you on the next slide, have sort of center finders where you're able to find facilities that will offer these services. And then there are other, support services that exist, both for learning more about third-party reproduction and also for the psychosocial support that's needed to kind of make these decisions and think through everything that goes into it. And this is just an example screenshot of the Find a Clinic feature of the Oncofertility Consortium, but the Alliance for Fertility Preservation has a similar feature called Fertility Scout. We're able, based on where you are and what service you're looking for, to find a facility that would kind of offer that. And that's it.
And we're a little slow. We're a little slow.
Questions? Thank you guys. It's pretty informative for us to have daughters or sons with APS1 or are carrying it on ourselves. So we have about 10 minutes for questions. We have microphone runners if you want to ask questions at this point.
Thank you for coming and sharing your knowledge. I really appreciate it. My question is, APS includes so many different things. So I'm wondering if you could speak to the potential impact of APS, including Addison's, on fertility.
Certainly. So autoimmune disorders tend to run in clusters. So if someone has Addison's disease without another endocrinopathy, they kind of independently have about a 20% chance of premature ovarian insufficiency, and sometimes we'll see the opposite in that another disorder will initially manifest, and then Addison's will be something that develops along the way. At the end of the day, having Addison's is not prohibitive of going through fertility preservation treatments. Many of those patients are requiring supplementation for their adrenal insufficiency. So they will, for example, around the time of the egg retrieval procedure, need supplemental hydrocortisone that's given or mineralocorticoids along that process. But we actually have many patients who, with Addison's disease, that will go through fertility preservation. Again, some may end up using the eggs in the future, some may not, but there are some special considerations in how we manage it medically, but it is something that we have seen together frequently.
I have a question down here.
Thank you for joining us today. I think that we have a lot of young girls in our group and here with us today. And I'm most interested to try to get ahead of it if we can, and try to predict as best we can if and when there's going to be a POI issue and what to do. So can you give us some additional thoughts on pre-pubertal surveillance techniques? Sure. So that we can try to optimize our options?
Right. So It's a great question, and I'll speak to it, and certainly you're welcome to add anything that you would have. But I think pre-pubertal, there's very little that we can do from a maintenance or a kind of surveillance perspective. It's really once a girl goes through menarche that we can use the typical ovarian reserve metrics. And as I mentioned, even those have some limitations in young girls. So prior to the onset of puberty, there really isn't much that can be done. But in one of the slides, what we did show is that the median age of going through premature ovarian insufficiency tends to be in late adolescence or beyond for this group. So I think the key is to work with an endocrinologist or one's general practitioner around that pubertal transition, so after menarche, to put together a plan for surveillance. And I would strongly encourage that that's done with a reproductive endocrinologist, because unless you have a pediatric endocrinologist that's very familiar with ovarian reserve testing, it can be a little bit difficult to really assess what do these trends mean and when is the right time to intervene. Because ideally, we would want to see these girls before they stop having periods or before their periods start to get irregular. That's really kind of almost, I don't want to say too late, but we don't want to be in that situation. We would really rather see them after menarche, but while they are still kind of either establishing their normal menstrual pattern or while they're having normal menstrual cycles. That's really the optimal time.
So just to follow up real quick, sooner than later would be optimal. Okay.
Yes.
Hi, thank you for your helpful talk. I am a pediatric endocrinologist. I haven't had the occasion to care for any young girls with APS1, but I'm wondering if serial monitoring of AMH beginning at a younger age might be helpful in the sense that one might see a progressive decline in the AMH levels prior to the FSH rising or other metrics that you might look at. And do you know if anybody's looked at that or if the natural history is known of the pattern of AMH decline?
It's a great question, and I think studying AMH in prepubertal and kind of the early time just after menarche, it has been looked at in terms of normative data, less so in autoimmune disorders. There are a couple of case series out there, but generally speaking, AMH has some degree of fluctuation in and of itself. And so, we see this in adult women as well. You can check a level 1 at one time and, 6 months later it might be exactly the same, or, sometimes we actually will see the level go up. So not everybody will always have progressive levels that go down. And in the adolescent population in particular, we expect the levels to either be, to go up, or they may actually be relatively steady for a while and then kind of peak around the age of 24. So I think the role of using AMH as a marker of ovarian, kind of reproductive potential in the adolescent population is still very unclear, because there aren't clear metrics that say, okay, well, if it drops by, this amount, this is when we should start to be concerned. So I think really in young girls, I think the combination of all three is actually going to be more helpful than just one single marker alone.
Question down in front, over the side.
So I don't know if you can even answer this question because it's kind of more of a philosophical or spiritual question, but I can have my take on how I feel about this, but I'm making decisions for my daughter who's 13, and I don't know what she's going to think, and it seems like we have to make these decisions now. Is there anything to do to help go through that process? I don't know, it's not really a medical question.
So like any guidance or anything?
Yeah, I mean, I would say if it's not in her cards to have kids, then she can adopt. That's how I feel about it. I don't know. She doesn't know how she feels about it. She's 13,
Sure. So maybe I'll start. Certainly add in whatever you like.
So with what we do at Cornell, there are a number of different members of the team who will meet with each patient or each couple or each family, depending on what the situation is. So we certainly have the physician doing the consultation, ordering testing, kind of managing the medical piece of it. We have genetic counselors, 3 genetic counselors on our staff. We have 3 psychologists who are specialized in reproductive medicine, as well as patient coordinators, social workers, and a variety of other support staff who sort of, not that anyone can answer that question, right? No one can really tell you, and this is something we often tell patients, is we're never going to tell you what to do. But kind of bringing up all of the different things to consider has been very helpful with a lot of these patients. And we see, even in very young girls, we've done ovarian tissue freezing in some girls as young as 5. And you can tell even from the end of that meeting with all these different people that they have a full understanding of what they're doing. It's not on a scientific level, certainly, but they'll say to us, I'm doing this so that maybe one day I can have a baby. And we really feel that kind of having that multidisciplinary approach to it and kind of walking everyone through the whole system allows for that decision making to take place. So it's a matter of finding the right resources.
All right, we got time for one more question.
Do you mind? Hi. This is a very, very, very sensitive subject for me. So if I'm shaky, that's why. I'm a 35-year-old APS1, and I didn't know I was APS1 until 5 years ago. And I didn't know that infertility was part of it until I saw Dr. Leonakis 2 months ago. I waited to have children after I got married at 24, and I couldn't. They do the normal standard, try it on your own for a year. So then I was like 25. And then I did IVF for 5 to 6 years until my kidneys failed. So I didn't end up, I did the IVF, but I'm different. So that's why I'm trying to ask, is I can make follicles on my own. I made like 17 follicles and I had like 20 embryos, but my lining was the one that was not responsive. So they did experimental drugs, they did everything. So I had a heart-shaped uterus. So I didn't know if that was something that was common with other APS. So I had a heart-shaped uterus with a thick septum in the middle. And then no matter how much estrogen that was pumped into me or vaginal Viagra or anything to get the blood to flow, I could not hold the embryo. So it sounds like it just feels like I'm a little bit on the different side. So I didn't know if that was an issue or common with could be common with the other girls.
It's a great question. And, most of the time, so what you're describing with the heart-shaped uterus with the septum is in a category of disorders called Mullerian anomalies. And there's a very wide spectrum of variations that we can see. They actually do not tend to occur at a higher frequency in patients with premature ovarian insufficiency from what we know. Now, I say that with a grain of salt because what we're talking about is 2 very rare disease processes. So, we're still talking on the order of, just a few percentages of the population, of the general population that are experiencing that. I think what you are speaking to is very difficult in terms of knowing kind of at what point in all of this to introduce a discussion about fertility and the various other ways that fertility may potentially be affected. And so generally speaking, as I mentioned, ovarian function tends to be the primary issue with APS, but there are also those other contributors as well. And so part of sort of that fertility evaluation with an endocrinologist or a reproductive endocrinologist usually involves not only an assessment of the ovaries, but also what's going on with the uterus. And thin lining is something that we struggle with as IVF practitioners in general. So I don't necessarily think that it is linked to the APS. I think those were probably two individual situations. Each of them can be handled separately, but so much of it is, like you said, it's timing, and also there are multiple ways to potentially attack a thin lining. It sounds like your doctor tried a lot of the things that we typically do as well.
All right, well, we got to wrap it up and take a break here. We thank you for sharing your knowledge with us. Are you guys gonna be around a little bit?
The mics are in the other.
They'll be around for a little bit if you have individual questions. Thank you, guys.